Serum antibody levels of a patient after the first and second exposure to antigen X are shown in the exhibit. This finding is representative of exposure to which of the following pathogens? Herpes simplex virus, influenza virus, Bordetella toxin, Neisseria lipopolysaccharide, or none of the above. As you look at the diagram, you see that there is no IgG production. However, after the first and second exposure, there has been only IgM production by the B cells. The correct answer is Neisseria lipopolysaccharide. I want you to know that this pattern of response is representative of Neisseria, LPS, and Thymus independent antibody formation. All other answer choices are associated with IgG response over time and a much more vigorous IgG titers after the second or subsequent exposures. Note that Thymus dependent response to antigen evokes IgG antibody switching and IgG responses, as you see in this classic diagram that I've shared with you earlier. So the picture at the bottom is typical Thymus dependent antigen antibody response. Children up to 5 years of age are not capable of producing effective antibodies against lipopolysaccharide antigens. What is the most likely explanation for this finding? Antigenic response against lipopolysaccharides of gram-negative bacteria is Thymus independent and involves direct mature B lymphocytic stimulation. Immature B cells are unable to induce Thymus independent response against lipopolysaccharide antigens of gram-negative bacteria. Thymus independent antigens can only activate mature B lymphocytes. The immune system of the children is not well developed before age 5, and additionally, the immature B cells are energized and they cannot elicit proper immune response. This explains why children up to 5 years are not capable of producing effective antibodies against polysaccharide antigens. What is Thymus independent antigen? Thymus independent antigens, in contrast to most protein antigens, produce antibodies by B lymphocytes without contribution of T helper cells. Major Thymus independent antigens include bacterial polysaccharides, polymeric proteins, and lipopolysaccharides. What are the type 1 and 2 Thymus independent antigens? As you can tell, we have two forms of these types of antigens. Thymus independent antigens are divided to two classes by the mechanism of activating B cells, namely Thymus independent type 1 and Thymus independent type 2. Let's first talk about Thymus independent antigen type 1. This type possesses intrinsic B cell stimulatory effects, and they can directly cause proliferation and differentiation of B lymphocytes via toll-like receptors without T cell stimulation and independent of their B cell receptor specificity. These antigens are classified as B cell mitogens because they induce numerous cell divisions in the B cells. Let's talk about Thymus independent antigen type 2, and you may refer to this diagram for understanding it. This type of Thymus independent antigen consists mainly of highly repetitive cell phase structures or epitopes of encapsulated bacteria, same way that I show with this purple color polysaccharide capsule. In contrast to type 1, they do not have an intrinsic B cell activating activity. The activation of B lymphocytes is caused by cross-linking of a critical number of B cell receptors, which leads to accumulation of B cell receptors and cross-activation of these receptors in cumulative effect. This results in proliferation and differentiation of B lymphocytes and production of the antibodies. Just bear attention that in this diagram, the immunoglobulin that you see is the IgM. And those IgMs that have coated the B cells, several of them are simultaneously getting involved in the process of IgM antibody epitope interaction. And of course, the more of these IgM antibodies are involved, the more powerful the effect of the IgM antigen interaction, and the more powerful effect they can send to the nucleus of the B cell. Thymus-independent type 2 antigens may activate only mature B lymphocytes. Immature B cells are energized, so they will not elicit any immune response. Must know facts about thymus-independent antigens. Thymus-independent antigens are not presented to cells via MHC molecules. They either directly activate B cells to proliferate or act as mitogen and stimulate B cell division in all B cells. Pathogens that induce independent antibody production are complex antigens that express repetitive epitopes that are mostly made up of repetitive carbohydrate units or contain toll-like receptor ligands. TI antigens are non-peptide antigens such as lipopolysaccharide, capsular polysaccharide, flagellar proteins such as flagellin, and dextran. TI antibody responses are mostly IgM isotypes, and they are short-lived, and they induce no memory. In contrast, thymus-dependent antigens are mostly IgG isotypes, and they are long-lived and induce memory. Let's look at the thymus-dependent antibody formation and class switching. Antigens are proteins that can be converted to peptides after phagocytosis by antigen-presenting cells, such as dendritic cells. And I'm showing a dendritic cell with a major histocompatibility complex type 2 on it, and it has presented an antigen on its surface. Interaction between cognate T helper cell and B cell are required for long-term memory and switching of the membrane-bound IgM to IgG. Proper interaction includes interaction between the CD40 proteins on the B cells and CD40 ligands on the T cells, and release of interleukin 4, 5, and 6 from T cells. The major antibody of thymus-dependent reaction is IgG. The interaction also causes formation of long-lived plasma cells in addition to memory B cells. As you see in this diagram on the B cells, I'm showing antibodies attached to B cells. Those antibodies attached to B cells are membrane-bound IgM antibodies. It's a good time for us to talk about conjugated vaccines. Conjugated vaccines has been helpful in inducing immune responses to polysaccharide antigens that are thymus-independent antigens, and as such, they do not induce T-cell mediated memory reactions. Conversion of polysaccharide antigens to thymus-dependent antigens by covalent coupling to an immunogenic protein carrier is a major milestone of modern immunology. Conjugated vaccines have been extremely helpful in reducing mortality in young children due to Neisseria, meningitis, and Haemophilus influenza. Conjugated vaccines are created by covalently attaching a poor polysaccharide antigen to a carrier protein, preferably from the same macroorganism, thereby conferring the immunological attributes of the carrier to the attached antigen. Note that polysaccharides by themselves cannot be loaded onto the MHC complex of antigen-presenting cells because MHCs can only bind peptides. In the case of conjugate vaccines, the polysaccharide peptide moiety can activate the T cells and allow the antigen to be loaded onto the surface of the MHC molecules. Conjugated vaccines are available against Haemophilus influenzae capsule, pneumococcal polysaccharides in case pneumovac, and Neisseria meningitis. In the case of Haemophilus influenzae, the vaccine is made by conjugation of the capsular polysaccharide of Haemophilus to diphtheria or tetanus toxoids. What is CRM-197? CRM-197 is a non-toxic, detoxified form of diphtheria toxin currently being used as a carrier protein for polysaccharides and haptens to make them immunogenic. A single mutation at position 52, substituting glutamic acid for glycine, causes the loss of Adp ribosyltransferase activity of the native toxin. It's a good idea for us to quickly review the concept of Adp ribosylation. Adp ribosylation refers to post-translational addition of one or more Adp ribose moieties to a protein. Ribosylation is important in cell signaling, DNA repair, gene regulation, and cell apoptosis. Adp ribosylation is also the basis for the toxicity of bacterial exotoxins such as cholera, diphtheria, and Pseudomonas. An 8-month boy is seen for evaluation of recurrent episodes of otitis media and respiratory infections for the past 4 months. He has been vaccinated against Haemophilus and has just finished a complete course of augmentin for otitis media. Measurements of serum immunoglobulin levels shows high levels of IgM and low levels of IgA and IgG. What is the most likely etiology of these findings? Would it possibly be mutation of proton tyrosine kinase, BTK, gene affecting B-cell maturation? Or mutation of CD4D ligands that are expressed on activated CD4 T lymphocytes? Would it be possibly due to NADPH oxidase deficiency that affects neutrophilic functions, or adenosine deaminase deficiency that affects B cell and T cell functions, or is it a defect in protein kinase that regulates cellular responses to breaks of DNA double strands? Well, let me give you the correct answer, and then I'm going to explain it for you. The correct answer is option B, mutation of CD4D ligands that are expressed on CD4 T lymphocytes. And as you see in this diagram, the CD4 ligands are defective on Th2 lymphocytes. As you can tell, the condition that I'm referring to is hyper-Igm syndrome, and we're going to be covering all the immune deficiencies in more detail for you later. But for now, this is a good sort of appetizer for what comes next. Now, just to know, the high levels of IgM and low levels of other immunoglobulins, and in particular IgG, after immunization with conjugated Haemophilus vaccine is highly suggestive of hyper-IgM syndrome, HIGM. This condition is characterized by mutations of CD40 ligand that are normally expressed by activated CD4 T lymphocytes. As a result of this defect, signals that are necessary for B-cell activation, antibody class switch recombination, and somatic hypermutation fail to be generated. The patients present with high IgM levels and deficiencies of all other immunoglobulins such as IgG, IgA, and IgE. Finally, I want you to know that HIGM includes a group of defects with similar findings, but the most common form of it is X-linked form of hyper-IgM syndrome. To give you a little keywords about the other distractors, I want you to know that the option E, defect in protein kinase that regulates cellular responses to breaks of DNA double strands, pertains to ataxia telangiectasia. This is a neurodegenerative disorder that is associated with ataxia and, of course, telangiectasia. The disease results from defect in serine threonine protein kinase that is activated after breaks of DNA strands. This enzyme normally phosphorylates several key proteins that initiate cell cycle arrest, DNA repair, or apoptosis. With regard to option A, mutation of proton tyrosine kinase gene that affects B-cell maturation, I want you to know that this gene, BTK gene, causes Bruton's agammaglobulinemia. BTK gene is critical for differentiation of pre-B cells to mature B cells. As a result of lack of mature B cells, the patients have low level of all antibody classes, including IgM. This is a critical difference between option A and option B. Finally, option D, adenosine deaminase deficiency. We have covered this concept in biochemistry. We're going to be covering it later when we cover all immune deficiencies. This defect causes SCED, and the patients present with combined B and T cell deficiencies. NADPH oxidase deficiency, which is option C, also causes chronic granulomatous disease, and it does not affect immunoglobulin levels. Again, we're going to be covering all of these conditions in detail later in immunology. What is the most effective treatment for patients with hyper-IgM syndrome? It just came up, and I'm sure that you're curious to know how you should treat these patients, and most likely you don't want to wait until I get to the point that I have to talk about all these immune deficiency conditions, where immunoglobulin replacement therapy and periodic administration of intravenous immunoglobulin, IVIG, significantly decreases the frequency of respiratory tract infections, in addition to other types of infections in these patients. Patients with HIGM are also at risk for susceptibility to pneumocystis carinii pneumonia, PCP, and it is recommended that they should receive prophylactic treatment with trimethoprim sulfamethoxazole. Due to defects in T lymphocytic functions, patients may also require hematopoietic stem cell transplantation, bone marrow, or umbilical cord blood stem cells. What is intravenous immunoglobulin? IVIG is a blood product derived from the pooled plasma of about 10,000 to 20,000 individuals in the communities or specific geographic localities. It is highly purified from plasma by cold alcohol fractionation. Most of the immunoglobulins in the IVG are of the subtype of IgG, but there are small and variable amounts of IgA as well. It's a good time for us to talk about important must-know cytokines. Before I do that, let's start with this good case scenario. A 22-year-old woman is seen for evaluation of a 3-month history of abdominal pain, intermittent diarrhea, and constipation. The workup of the patient includes stool sampling that is positive for occult blood and serology that is significant for eosinophilia. The patient is scheduled for a colonoscopy that reveals multiple areas of mucosal inflammation. Biopsy of the inflamed segments establishes eosinophilic colitis. She is treated with mebendazole that results in rapid resolution of symptoms and disappearance of the eosinophilia. Elevated serum levels of which of the following cytokines have most likely contributed to the presumptive diagnosis of the patient? Interleukin 1, 2, 3, 4, or interleukin 5? The correct answer is interleukin 5. Just to know, the patient most likely has a helminthic disease. Eosinophils are tissue-dwelling cells, and they are present in the lamina propria of the gastrointestinal tract, acting as a shield against the intestinal parasites. The serum and colon laminal levels of eosinophils significantly increase in the helminthic and parasitic diseases. In addition to eosinophilia, T helper 2 associated responses with production of interleukin 5 are also common findings in parasitic conditions. Eosinophils respond to allergens and parasites by degranulation and release inflammatory mediators, including glucotrienes, vasoactive intestinal peptides, tumor necrosis factor, and interleukin 5. Note that interleukin 5 is also produced by mast cells and T helper 2 cells. Another important contribution of interleukin 5 in helminthic diseases is that it promotes differentiation of B cells and promotion of class switching to IgA that is secreted into the GI lumen. It is postulated that IgA paralyzes worms. Another antibody that is increased in helminthic diseases is IgE. It is postulated that IgE coats the cell surface of the parasites and triggers mast cell degranulation that leads to perforations of the skin of the parasites. The IgA, on the other hand, increases the intestinal motility and promotes diarrhea and expulsion of the worms. Note that eosinophilic colitis, that is evidenced by colonic biopsy, is not uncommon with gastrointestinal parasitic infections. Also note that the most common gastrointestinal parasites in the US are Giardia lamblia, Entamoeba histolytica, Ancylostoma duodenale, Necator americanus, and Enterobius vermicularis. In the next few plates, I'm going to be looking at the major cytokines that are produced by different cells of the immune system. First and foremost, we're going to be looking at the cytokines produced by macrophages. There are 5 major cytokines: interleukin 1, 6, 8, 12, and tumor necrosis alpha. What is the function of the interleukin 1? This interleukin is an acute phase protein and produces inflammatory response. It causes fever and edema. It stimulates endothelium and induces adhesion substances. Also, I want you to know that interleukin-1 is formed by osteoblasts, and it can also activate osteoclasts. Interleukin-6 is also an acute phase reaction and inflammatory interleukin. It is a pyrogen. It causes fever. It induces B-cell differentiation. I want you to note that interleukin-6 is also known as B-cell stimulatory factor 2. B lymphocyte stimulatory factor 2. Interleukin-6 is also produced by T cells and endothelial cells. Interleukin-8 enhances inflammation. It causes neutrophil chemotaxis and neutrophil activation. If you recall, this is a major interleukin that causes attraction of the neutrophils to the site of inflammation. Interleukin-12 activates natural killer cells. It also activates conversion of CD4 cells to T helper type 1 cells. Finally, tumor necrosis factor alpha is a pro-inflammatory cytokine. It acts on endothelium, induces nitric oxide production, and promotes fluid leakage. Lock in this information. This information is very important, and we're going to be talking about super antigens and septic shock a little down the road. But for now, just remember, if they ask you on the exam, what is the compound that most likely involved in septic shock and may potentially cause serious hypotension and potentially can be deadly, is TNF alpha. It causes fever, it causes severe shock. 3 major cytokines are produced by T helper 1 cells: interleukin-2, 3, and interferon gamma. Another name for interleukin-2 is T cell growth factor. It promotes, as the name implies, promotes the growth of T cells. It also stimulates B cells, natural killer cells, and CD8 positive T cells. Interleukin-3 is produced by all T helper cells. It is a growth factor for hematopoietic cells. It has similar function as granulocyte, macrophage, colony stimulating factor, GM-CSF. Interferon gamma causes activation of natural killer cells and macrophages. It causes production of antiviral effects in the nearby cells. It causes inhibition of T helper 1 and 2 cells. It induces major histocompatibility type 1 and type 2 expression. It also inhibits cancer cells. Finally, cytokines that are produced by T helper 2 cells. There are 4 must-know ones: interleukin-3, 4, 5, and 10. Interleukin-3 is produced by all T helper cells. It is a growth factor for hematopoietic cells. It has similar function as granulocyte, macrophage, colony stimulating factor. Interleukin-4 causes activation and growth of B cells, isotype switch, and plasma cell formation, promotes isotype switch, and induces production of IgG, IgE, and major histocompatibility complex by the B cells. It induces expression of MHC2 proteins on macrophages. It inhibits interleukin-1 and tumor necrosis factor alpha. Interleukin-5 causes growth and activation of the eosinophils, induces B-cell class switch and IgA production. Interleukin-10 is made by Treg cells, inhibits Th1 and stimulates Th2 cells. It inhibits macrophages, and interleukin-12 that is made by the macrophages. It downregulates antiviral responses via inhibition of interferon gamma. As you can tell, the only thing that you can do about these cytokines is that to commit them to your memory. So you look at these tables a few more times, maybe chat down a little note until you master them. And again, I'm bringing to your attention the fact that interleukin 10 inhibits interleukin 12. So T helper 2 cells have effects on T helper 1 cells. We have already covered this concept earlier. A mnemonic that some students like to remember these interleukins is hot T-bone steak. And the numbers of these essentially interleukins progressively increase from 1 to 5. Interleukin 1 for hot, for fever. Interleukin 1 causes fever. Interleukin 2 for T-cell stimulation. Interleukin 3 is a bone marrow stimulator. It acts like GM-CSF. Interleukin 4 causes formation of IgE and causes class switching from IgG. It also causes B-cell growth. Interleukin 5 causes IgA production and stimulates eosinophils. So hot T-bone steak for interleukin 1, 2, 3, 4, 5. In an experiment, freshly isolated murine Peyer's patch B cells were cultured with interleukin 4, interleukin 5, interleukin 7, interferon gamma, and tumor necrosis factor alpha to investigate role of these cytokines in induction of immunoglobulin synthesis. Among the tested cytokines, which one is the most effective one in raising the serum IgA levels? You should know the answer by now. This one should be interleukin 5. And I'm going to be referring to this diagram. I'm showing a helminth at the bottom of the diagram. Just to know, interleukin 5 has the most potent effect in stimulating B cells to produce IgA, or acting as a differentiation factor for IgA isotype switch. Interleukin 4 has a more prominent effect on IgE and IgG production. Interferon gamma causes activation of natural killer cells and macrophages, and it has antiviral effects in nearby cells. Finally, tumor necrosis factor alpha acts on endothelium. It induces nitric oxide production, and as such it promotes vasodilation, fluid leakage, and it may cause fever and shock. What cytokine has been heavily studied and employed in cancer therapy? Interferon alpha. It is currently used for treatment of hairy cell leukemia, nodular lymphoma, Kaposi sarcoma, papilloma, melanoma, and renal cell carcinoma. What interleukin is most effective in producing IgG class switch? This is interleukin 4. Some bacteria can cause septic shock. What interleukins are mostly associated with the symptoms of septic shock? Interleukin 1, 6, and tumor necrosis factor alpha are all associated with sepsis syndrome. Note that severity of sepsis is based on the extent of organ dysfunction as a result of systemic hypoperfusion and widespread anaerobic respiration. These cytokines play two contrasting roles in sepsis. On one hand, they are vital for fighting the infections. On the other, their excessive production leads to tissue and organ damage. Within pathophysiological limits, these cytokines activate endothelial cells and stimulate them to release selectins. And these selectins increase the stickiness of endothelium for innate cells, while also increasing endothelial leakiness to allow for delivery and chemotaxis of the innate cells into the affected tissues. It is apparent that excessive leakage of vascular fluids is one of the major factors in determining the prognosis of patients with septic shock. What class of pharmaceuticals have been targeting cytokines that cause exaggerated endothelial leakage and hypotension? As you can tell, this class of pharmaceutical may have a promising role in managing the deadly consequences of sepsis syndrome. Well, these are anti-tumor necrosis factor alpha monoclonal antibodies. To give you a few examples, infliximab, brand name is Remicade, adalimumab, Humira, certolizumab, Cimzia. So what is the most common usage of anti-tumor necrosis factor alpha monoclonal antibodies such as Humira? They are heavily used worldwide to treat inflammatory conditions such as rheumatoid arthritis, psoriatic arthritis, juvenile arthritis, inflammatory bowel diseases such as Crohn's and ulcerative colitis, and ankylosing spondylitis. What are the major acute phase proteins that are induced by interleukin 1, 6, and tumor necrosis factor alpha in response to infection, to tissue injury, necrosis, or malignancy? These are C-reactive protein, alpha-1 antitrypsin, serum amyloid A, complements, fibrinogen, and finally ceruloplasmin and haptoglobin. So what organ makes these acute phase proteins? As I've said it over and over and over again, if you don't know what organ makes what particular substance, always guess liver, and for most part you may be correct. And it is true in this case that liver makes the acute phase proteins, for most part. Now, how does local activation of macrophages and their interaction with pathogens attract neutrophils to the site of inflammation? In responding to this question, I want you to have this picture in mind, and as usual, I have numbered the specific stages for you from number 1 all the way to number 8 in this diagram. Tissue invasion by pathogens. This is stage 1. And the presence of pathogen-associated molecular patterns, the PAMPs, on them activates tissue macrophages that are the first innate system responding cells. Of course, I'm not showing the macrophages, but I'm showing inflammation that has happened locally in the tissues as stage number 1. Upon activation, as we have said before, macrophages produce interleukin 1, interleukin 6, and tumor necrosis factor alpha, that they all have local and systemic effects both. Interleukin 1, interleukin 6, and tumor necrosis factor alpha, now they activate endothelial cells and they express E-selectin, E for endothelial. Selectins are glycoproteins and cell adhesion molecules. Adhesion molecules, CAMs. They are present not only on endothelial cells, but also on leukocytes and platelets. Another subclass of these selectins is P-selectins, and these will allow the leukocytes and neutrophils to migrate to the periphery of the vessels and slow down. The combined effects of blood flow velocity and selectins will cause the leukocytes to undergo the so-called rolling and tethering as they approach the endothelial wall. This is event number 4. And as you see from the center of the blood vessel, this neutrophil gradually gets, while it rolls, gets closer to the wall of the vessels. Meanwhile, integrin molecules that are expressed on the surface of the endothelial cells and leukocytes will allow the two cells to firmly attach to each other. Activated tissue macrophages, meanwhile, from a different angle, they have already also produced interleukin 8, that is also known as chemotactic factor for neutrophils. We have already covered this. Interleukin 8 will allow the neutrophils to do diapedesis, to pass through the leaky blood vessels towards the site of inflammation. These are events 7 and 8 in this diagram. I want you to note that interleukin 1, interleukin 6, and more importantly, tumor necrosis factor alpha, they all cause leakiness of the endothelial cells. And this will facilitate diapedesis of the leukocytes through the vessel walls. A 22-year-old college student is rushed to the emergency room by her roommate with fever, hypotension, and inability to void more than 12 hours. On examination, she is confused and has diffuse rashes resembling scarlet rash on her skin. Her temperature is 103.5 Fahrenheit, pulse 140, blood pressure 72/35, respiratory rate 25. Her roommate states that her friend has a history of heavy menstruation and regularly uses tampons, and she has been admitted to hospital 4 months ago with similar symptoms. Well, what comes to your mind? Confusion, diffuse rashes on the skin, high temperature, fever, very low blood pressure, high respiratory rate, use of tampons. These are all important key words, and this is going to be important for the next important subject that I like to discuss for you. Of course, most of you might have been thinking of septic syndrome. Most of you have been thinking of sepsis. If any one of you is thinking about sepsis, you're correct. So this brings us to answer the question. Given these findings, what is the most likely cause of the patient's symptoms? Toxic shock syndrome due to Staph aureus and as a result of use of tampons. Let's keep this question in the background. My first important question for you: what is toxic shock syndrome toxin? Toxic shock syndrome toxin, TSST, is a super antigen produced by 5 to 25% of the Staph aureus isolates. It causes toxic shock syndrome, TSS, by stimulating release of large amounts of interleukin 1, interleukin 2, and tumor necrosis factor. And that's how the toxic shock syndrome is going to be related to the interleukins that we just covered. The toxic shock syndrome toxin is a prototypic super antigen. Look in that name, super antigen. It is not produced by bacteria that are growing in the blood. Lock in also this information. The super antigen is not produced by the bacteria that are growing in the blood. Rather, it is produced at the local site of an infection, then enters the bloodstream. Now we are back to this major question, and let us together see what is a super antigen after all. Super antigens, SAGs, are a class of antigens that cause non-specific activation of T cells. Lock in this information. Non-specific activation of the T cells, resulting in polyclonal T cell activation and massive cytokine release, locking these high-yield facts. Polyclonal T cell activation. Not just one colony of the cells, several different colonies of T cells. Unlike conventional antigens, these antigens are not MHC restricted. They are not major histocompatibility complex restricted. What does this mean? It means that they are not processed by the formal procedure of presentation by the antigen presenting cells. This means that they circumvent the APCs. And what they do instead is that they directly and strongly bind the major histocompatibility complex 2 of the APC cells and the T cell receptors to each other, locking this information. So they bypass the APCs, but they lock in the TCR like a very strong glue to the MHC2 complexes. Also, another must-know fact, also in contrast to conventional MHC-presented antigens that are composed of fragments, small fragments of up to 13 amino acids, fragments of the original antigens, the epitopes that we have covered, the super antigens are global, they are big, they are composed of the intact antigen, which has many more amino acids. Or in a sense, the super antigens contain several epitopes inside them. So let's look at the mechanism of action of superantigens. And in order to understand it, we're going to be referring to this diagram, and I'm showing a pathogen on top, and I'm showing the antigen of the pathogen with a purple color. And I'm showing one APC cell, one dendritic cell on top. I'm showing also a T helper cell, CD4 positive T helper cell, and then I'm showing how production of the interleukin 2 by this T helper cell will cause formation of the Th1 cells and will cause formation of interferon gamma by these T helper 1 cells, that they activate and cause production of more natural killer cells. Then they also activate macrophages, and I'm showing how the macrophages produce interleukin 1, 6, and tumor necrosis factor, and how these factors cause formation of severe shock and organ failure. So let's go through this together. Unlike other antigens that must be internalized within the APC cell and then processed by MHC1 or 2, superantigens directly cross-link the T cell receptor to MHC molecules. So as you can see in this diagram, they bypass the APC cell and lock in the T cell receptor to MHC2 molecules. You have two legs in here, so it's MHC2. These antigens can be bacterial, viral, or retroviral proteins that, in contrast to classical peptide antigen recognition, do not require processing to smaller fragments or peptides, and they act as complete or partially processed proteins, locking this information. The key cytokine that is released in response to activated T cells, to more specific Th1 cells, is interferon gamma, which greatly activates macrophages. Of course, it also activates natural killer cells. Activated macrophages are the ones that in the tissues release high amounts of interleukin 1, 6, and tumor necrosis factor. So, superantigens cause notorious production of interleukin 1, interleukin 6, and tumor necrosis factor alpha. Too much production of tumor necrosis factor alpha in particular causes life-threatening hypertension and organ failure. Okay, another important high yield factor I want you to know about the Staph aureus and toxic shock syndrome toxin 1. Majority of the patients with TSST1 may suffer repeated episodes of TSS without mounting proper IgG response. So on the exam, always look for a history. And we had that history in the same case scenario that I presented to you. The friend of the patient said that she has had similar symptoms in the past. So these patients may have history of several other episodes of having hypotension or septic shock without mounting proper IgG response. This is most likely due to release of interferon gamma that tends to inhibit immunoglobulin production. So what is the reason that they don't mount proper immunoglobulin response? It is most likely as a result of too much interferon gamma production that tends to inhibit immunoglobulin production in these patients. What is the main difference between monoclonal and polyclonal activation of B cells? Remember that we said that in toxic shock syndrome, or in the case of superantigens, these antigens, in contrast to normal antigens or common antigens that usually initiate monoclonal antibody production, they initiate polyclonal activation of the B cells. So what is the difference between monoclonal and polyclonal activation of B cells? Antigen-presenting cells normally provide one epitope with a high degree of specificity on their MHC2 complexes. This results in activation of T cells that produce clones of cells that only express antibodies against that specific epitope. The superantigens, on the other hand, are non-specific and cause activation of a multitude of T cells producing many antibody-producing clones, so-called polyclonal, that instead of specifically targeting the pathogens, they cause widespread activation of the immune system. A monoclonal antiviral antibody has potent antiviral effects. However, polyclonal antiviral antibodies, they have weak antiviral effects. So instead of helping to target the viruses, as you can guess, they tend to damage the host more than helping the host cells. Also note that compared to a normal antigen-induced T cell response in which less than 1 in every 1,000 of the bodily T cells are activated, superantigens are capable of activating up to 25% of the body's T cells. This brings us to do a short list of the diseases associated with superantigen. Eczema, psoriasis, Kawasaki syndrome, rheumatic fever, rheumatoid arthritis, scarlet fever, toxic shock syndrome, infective endocarditis,